Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to thank Lasamir for this kind invitation and the organizers. It's a great honor and pleasure. I've been asked to talk about the progression of ectatic corneal diseases. We can define the progression of ectatic corneal diseases as corneas becoming more distorted, thinner, steeper, in addition to more deterioration of the quality of vision. To go through this topic, we have to ask ourselves, is it really progression? And we have to know the factors affecting progression, and then we can learn about the criteria of progression. Starting with, is it really progression? Actually, we know the impact of the ocular surface disease and dry eye disease on the accuracy of measurements in the cornea itself and visual acuity, not only in normal people, but as well in keratoconic people. And we have to know that there is a diurnal fluctuation of vision, especially in ectatic corneal population. And we have to know that there is an effect of the eye rubbing on the accuracy of measurement apart from the impact of eye rubbing on the progression itself. The way to test vision has a big role in giving false results, especially if it is carried by different optometrists in every visit and different way of test vision and charts in every visit. We know the impact of the dry eye disease. It alters the shape and the regularity of the anterior corneal surface. The tear film instability will cause irregularities, will cause changes in the epithelium, and will induce some higher order aberrations. Moreover, tear film instability leads to unstable vision, blurry vision, inaccurate K reading measurements, and therefore inaccurate biometry. Now we come to the factors affecting progression. There are true factors affecting progression and false factors affecting progression. Starting with the false factors. We have to exclude usage of contact lenses before deciding of progression. Therefore, contact lenses should be stopped at least 2 weeks before doing any measurement to a cornea with ectatic corneal disease. Misalignment during taking the capture may alter the results as well. Large angle kappa, tear film disturbance, corneal opacities or pathologies, and bad exposure to the camera all are factors causing false findings. However, true factors affecting progression are the age. According to this study, we can see that age younger than 18 years has more aggressive and more incidence of progression compared to those who are between 18 to 26 years of age and those older than 26 years. This is a similar study giving the similar result. On the other hand, keratoconus may continue to progress beyond the age of 30. So there is no guarantee at age of 30 that the disease stops progression. We have to keep on monitoring the eyes. Kmax is a factor according to this study for progression. According to this study, those with a Kmax steeper than 55 diopters at presentation had significantly greater risk of progression compared to those with less than 55 diopters. Eye rubbing has been described by Damien Gatinel. He was the first one to describe the effect of eye rubbing not only on the quality of vision and measurements, but as well on initiating progression and the continuous progression of ectatic corneal diseases. And he came out with his very famous say, no rub, no cone. We come to the criteria of progression. Let's say chronically we can go through, or let's say in the literature, the parameters of progression went through this development. single parameters, multiple parameters, then the development of classifying software, and recently the artificial intelligence, which was implemented in order to get better understanding and better inspection of progression. We can categorize the progression criteria used through the literature into visual acuity parameters, changes in refraction, Kmax and Kmean, pachymetry, including, of course, the central and the thinnest corneal thickness, changes in the topo asymmetry, changes in the topometric indices, and changes in the higher order aberrations. Starting with the single parameters, most of the old studies used the Kmax as a single factor to describe progression, most of them. However, Kmax itself cannot be an indicator, an individual indicator. Why is that? Because according to Epstein and Associates, if we are taking only one capture per visit, we have to consider a change of Kmax more than 1.5 diopters in order to say there is a progression. But if we are taking 5 captures, then the noise of the machine can be reduced to be as short as or as small as 0.68. So if it exceeds more than 0.68 diopters of a Kmax change, we can say it is progression. Moreover, the Kmax, if the Kmax is more than 70 diopters, then the Kmax measurements will be much more variable, and which means that the noise of the machine will be much wider. Now, in Hashimi et al. Study, there was a weak repeatability when the Kmax was more than 55 diopters. So from those two studies, we can say that the higher the Kmax, the more the distorted the cornea, and the less repeatability and the less validity of the Kmax measurements, and which means that the more the noise from the machine. So the restrictions of the Kmax, the degree of ectasia cannot describe the degree of ectasia, cannot describe the posterior surface. It is prone to artifacts, and it is altered after corneal cross-linking. What about the tomographic indices? The restrictions are, most of them derived from the anterior surface. They cannot describe the posterior surface. The changes may occur on the posterior while the anterior remains stable. They are not specific for ectasia because they describe irregularities rather than ectasia. What about the visual acuity and refraction? The restrictions of using this parameter are, there are different methods to measure the visual acuity, variable methods of refraction used by the optometrists, and they are dependent on the optometrists. The accuracy of the refraction and the visual acuity in advanced cases is questionable. However, some cases of progression are associated with visual acuity remaining stable and sometimes improving in spite of the progression because the cone is becoming more peripheral. The restrictions for using the corneal thickness parameters, the thinnest corneal thickness is more reliable than the central corneal thickness because the central corneal thickness does not represent the cone, and the progression may not affect the central of the cornea, the center of the cornea. However, both are affected and altered after corneal cross-linking. What about the elevation maps? They are very much affected by the automated position and diameter of the best fit reference surface chosen by the machine automatically. Using the higher order aberrations is very much affected by factors of false findings. Therefore, there must be multiple parameters to be considered rather than single parameters. Many indices were developed in many machines. Every machine has its own indices, and each index is a complex of parameters in order to derive to 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 to, to get let's say better um, description of what's happening in the ocular surface and the corneal in the cornea itself. However, those indices describe the asymmetry, decentration, and the deviation from the normal population. Very important to note that there is no black and white in those indices. There is a gray zone of suspected cases. Many softwares were developed in order to give the probability towards abnormal or towards normal. Multiple parameters as well were described better by the global consensus on keratoconus and ectatic corneal diseases that came in 2015. And it described the progression to be out of the normal noise of the testing system in terms of progressive steepening of the anterior surface, progressive steepening of the posterior surface, and changes in the thickness, like thinning and changes in the spatial profile. However, it did not give any recommendations regarding the parameters and cutoff values because different machines can give different values, and the noise of the machine will differ from a machine to another. And the range of variability differs according to the number of captures per session, and the variability increases in distorted corneas. And finally, patient's cooperation during taking the capture has a big role. Classifying software. Some software were developed in order to give better results in describing the progression, like the Belen ABCD keratoconus staging, which is available in the Pentacam and the Cyrus and the MS39. It depends, or let's say it describes the changes that occur in the zone surrounding the thinnest location, including the radius of curvature, which becomes shorter in progression, and including the thinnest location and the visual acuity changes. And then it gives a stage, and if the stage gets more, then there is a progression. In the ORB scan, the radar map was developed, and a score is given to each case. So the higher the score and the larger of the plotted area of the radar means larger or more progression. It depended on some parameters, and it gives the sensitivity of 71% and specificity of 98%. Most recently, artificial intelligence is being used in order to improve the prediction of progression. The latest article was published by Rohit Shetty. It's a very nice article, and I would advise everyone to read it. What's more, epithelial mapping and corneal biomechanics. We know that the epithelial map can describe progression in terms of focal thinning, inferior superior asymmetry, radial thinning, and the generalized thinning. However, we have to know that the epithelium does not show the progression until late stages because the ectatic corneal disease usually starts on the posterior corneal surface, and any change on the anterior corneal surface can be compensated by the epithelium in order to keep the anterior surface of the cornea very smooth and regular. And when irregularity starts showing on the anterior maps, it means that the epithelium cannot compensate anymore. But that does not have anything to do with the progression. However, some softwares are being used in order to check the thinning of the epithelium over the cone and the thickening of the epithelium above the cone. We come to the corneal biomechanics. We know that there are two machines describing the biomechanics, the ocular response analyzer and the Corvus. The ocular response analyzer can check the progression by giving the KMI index, and the Corvus by giving the CBI and TBI and describing the cornea is becoming softer. So to take home message, exclude false factors. Be sure it is progression. Be familiar with the criteria related to your device and depend on multiple criteria. Now, let's assume that I don't have artificial intelligence and I don't have the Bellin ABCD keratoconus staging or the radar of the Orbiscan. So what shall I do? What I do is I ask the same optometrist to take 3 captures per visit and then to compare the average K and the average thinnest location, the average K max, I mean, and the average thinnest location. If the change exceeds 1.5 diopters in the K max and 15 microns in the thinnest location, then I will consider it as progression, as in this case. However, these 2 parameters can be misleading after corneal cross-linking because we all know that the K max will increase after doing the corneal cross-linking, and then it goes back to its preoperative baseline after 6 months. On the other hand, thickness will be thinning, corneal thickness will become less immediately after the corneal cross-linking, and then it goes back to its preoperative baseline after 1 year. So we can see that during the first 6 months post corneal cross-linking, the changes in the Kmax and the changes in the thickness will be very similar to progression of ectatic corneal diseases. Therefore, during the first 6 months, you cannot make a decision whether there is a failure of corneal cross-linking and whether there is a progression of keratoconus. You have to start your observation just after 6 months of corneal cross-linking. For listening.